Hello, good day everyone. My name is Manjula Narasimhan. I work in the Department of Reproductive Health and Research at the World Health Organization, and I will facilitate today's webinar that is being jointly hosted by the World Health Organization, UNFPA, and Implementing Best Practices Initiative, IBP. I'd like to start by thanking Adas May from IBP and also Johns Hopkins, an independent consultant, for WHO for their support in the hosting and the logistics for this webinar. This webinar today is actually the fourth in a series of discussions that have been organized on strengthening linkages between sexual and reproductive health and rights and HIV. And it's really part of a series of activities undertaken by the Interagency Working Group on SRHR and HIV linkages. The next meeting of this working group will be from the 14th to the 16th of November in Nairobi, following the ICPD summit. And all the members of the Interagency Working Group are, of course, invited to attend. And for those of you who would either like to join the working group or would like more information on the working group and the tools that are available on SRHR and HIV linkages, please do feel free to contact Tim Sladden at UNFPA or myself. So to come to the topic of this webinar on the ECHO trial. So ECHO is short for Evidence for Contraceptive Options and HIV Outcomes. And this trial was a multi-site, multi-country, randomized clinical trial designed to compare 3 effective methods of contraception, and really to determine whether using any of these contraceptive methods is linked to an increased risk of HIV acquisition. So the results of the trial were published in The Lancet in June 2019 and also disseminated at international AIDS conferences, more recently in Mexico City in July 2019. In brief, the results showed that all 3 methods of contraceptive included in the ECHO trial were found to be safe and effective for pregnancy prevention, and that there was no statistically significant difference in the rate of HIV acquisition among the women in the trial. The HIV incidence, though, among the study population was high, and STI prevalence, such as gonorrhea, chlamydia, and herpes, was also high in the trial participants. What this shows is the need for strengthening those linkages between family planning, between STI and HIV. And although more information about the trial will be shared by the excellent presenters we have on this webinar, and you can also find out more information on the handouts that you'll see on the right side of the screen. This was really the thinking behind holding this webinar, to try and look at the results of the ECHO trial and see what this might mean for integration and for linkages between family planning and HIV services. So during the presentations, feel free to type in your questions that you may have, both in the question box on the control panel on the right side of your screen. And at the end of all the presentations, we will direct the questions to a panelist. In case we don't have time to answer all the questions, we'll get back to you after the webinar. Now, it's my pleasure to introduce our first panelist, Rose Wilcher from FHI 360. Rose, please go ahead.
Great, thank you, Manjula. And hi, everyone. It's great to be with you today. Just to start, I guess there's a little bio of me there. I do want to say that while I work for FHI 360, and FHI was one of the organizations involved in implementing the ECHO trial, I personally was not involved in the trial at all. However, I have spent a fair amount of my time at FHI 360 working on issues pertaining to sexual and reproductive health and HIV integration. So I'm very happy to have the opportunity to sort of put that hat back on and weighed into the conversation around integration in the aftermath of the ECHO trial. Next slide. So I'm assuming that everyone on the webinar today is familiar with the trial and even its results. And if you're not, as Manjula mentioned, we do have some nice summary resources on the screen there for you that you can download. But just to give the 2-second summary and sort of reiterate what Manjula already said, the ECHO trial measured HIV incidence among African women assigned to one of 3 highly effective contraceptive methods. The trial found that HIV incidence was high for all 3 groups, but it did not find a substantial difference in HIV risk among the methods evaluated. Okay, so that's the 2-sentence recap. And by the way, this summary slide was 100% plagiarized with permission from Jared Baton, one of the ECHO investigators. Next slide. Okay, so what does this mean for policy and practice? Again, with credit to Jared, he gave a great presentation at IAS this summer where he boiled down the implications of the trial results into 5 key takeaways. And I want to just quickly recap those here for you. So first of all, the primary results underscore the importance of continued and increased access to the 3 contraceptive methods evaluated in the trial, as well as expanded contraceptive choices. Because again, while HIV incidence was high, contraception was not found to be the primary driver. Number 2, more aggressive HIV prevention efforts for women, including PrEP, are urgently needed. Again, even though women in the trial received an individualized HIV prevention package, HIV incidence was alarmingly high. Number 3, we have to tear down the silos. So ECHO brought attention back to the intersections between the family planning and HIV worlds, and this connection cannot be lost. Implication number 4, so STI prevalence and incidence was also high in ECHO, highlighting the need for new screening, treatment, and prevention strategies for this other aspect of women's sexual health. And implication number 5 is that we must integrate services and put women at the center. So basically, women want and they need HIV and family planning and other sexual and reproductive health services in the same room with the same provider at the same moment. And there's really been a tremendous rallying cry around this last point since the ECHO results were announced. And I believe it's in large part because integrating sexual and reproductive health and HIV services is going to be one of the key mechanisms by which we're going to move the needle on all of these other programmatic implications. Next slide. And just to give you a sense of how loud the call for integration has been in the wake of the ECHO trial, I've included here a few snippets from the official statements that different organizations issued after the results were announced. And what you can see here is all of them mention the importance of integrating family planning and HIV services. And these are just a couple of examples, but really this call for integration has been embraced and endorsed by just about everyone with skin in this game. Next slide. And then, of course, within the last couple of weeks, WHO issued updated guidance on contraception for women at high risk of HIV, taking into account the ECHO results. And here too, you'll find a very strong call for integration of services. Next slide. Okay, so why the emphasis on integration? Well, because integrating sexual and reproductive health and HIV services can help ensure that women living with HIV and women at high risk of HIV can access information and services that empower them to fulfill their sexual and reproductive health needs, goals, and rights. But truth be told, we did not need ECHO to tell us this is important and something women want. Of course, if ECHO brings renewed attention to the cause and catalyzes meaningful action and investments in it, then that's fantastic. But the call for better integration of SRH and HIV services is not a new one. Next slide. And that's actually really good news for those of us who are now mobilizing and getting re-energized about advancing the SRH and HIV integration agenda in light of ECHO, because it means there's already an incredible and actually constantly evolving body of evidence to guide those efforts. And what you see here are journal supplements dedicated to SRH and HIV integration that have all been published in the last few years. And in fact, there was even another supplement published in Reproductive Health just a few weeks ago. And these supplements represent just a small slice of the evidence base on how the SRH and HIV needs of individuals are connected and how they can be better addressed through integrated policies, systems, and services. And of course, ECHO has certainly added to this evidence base. Next slide. Now, ECHO focused specifically on the intersections between contraception and HIV. So many of the calls for integration have also focused specifically on the integration of family planning and HIV services. But the calls to also put women at the center of the response require a broader perspective, one that considers women's comprehensive sexual and reproductive health needs. And when you start talking about integrating SRH and HIV services, that can encompass a fairly broad constellation of services, with the entry points and the combination of services provided depending totally on the needs of the individual being served and taking into consideration factors such as her HIV status, her pregnancy status, whether she has experienced violence, and so forth. But that being said, one thing ECHO made very clear is that we really need to be more intentional about addressing HIV in family planning clinics, especially in high HIV burden countries. Women in these settings accessing family planning services should not only be able to learn their HIV status, but should be offered voluntary partner testing services, STI services, violence screening and response. Women who test positive should be linked to ART services, and women who are negative should be offered PrEP. Next slide. And what impact will it have? So some configurations of integrated services have more evidence behind them than others. For example, there has been far more research on service delivery models that integrate family planning into HIV services than vice versa. But taken together, the data increasingly suggest that integrated SRH and HIV services can lead to a number of positive outcomes, many of which you can see listed here. But of course, there's always a need for more research, and indeed, ECHO has prompted a lot of discussion about the need to explore new integration models and approaches. Models and approaches such as how innovations like HIV self-testing and PrEP can be integrated into family planning services. Now, like I said, I'm very excited there's renewed interest in service integration after ECHO. But the other big thing that I think ECHO tells us is that integrated services aren't going to be a magic bullet solution. The fact that women participating in the trial received HIV prevention services but still had high HIV incidence suggests to me that service delivery interventions alone aren't going to solve everything. Next slide. And that's because sexual and reproductive health and HIV intersections are also structural in nature. Many women are at risk of both unintended pregnancies and HIV, as well as STIs and other poor SRH outcomes, because of structural drivers like gender inequality, gender-based violence, stigma, and discrimination. Drivers that essentially serve to reduce power and can make it really difficult to access services and even exercise control over our own bodies. And I think this is really important to keep in mind as we heed these calls to strengthen the integration of SRH and HIV services. Next slide. Because ultimately, the impact of providing integrated SRH and HIV services will be maximized when those structural barriers to service uptake are taken into account and addressed, when health systems are strengthened to support integrated delivery of services, and when those services are women-centered with attention to human rights and gender equality. And fundamental to this last point is really ensuring that care is provided in a way that respects women's autonomy in decision making about their health, and it includes unbiased information and options so that women can make informed choices. Next slide. So in closing, I'd just like to say that, we must take the results of ECHO and make them actionable. And strengthening SRH and HIV service integration with women and girls at the center of those efforts should be a priority for all of us. And importantly, we're not starting from scratch. A great repository of resources has been developed and compiled over the years, and many of them can be found here in this toolkit that you see on the screen. So, I encourage all of us to take this agenda forward, building on the evidence and resources that are already there, because there is a really solid groundwork from which we can build. And that's all for me. Thank you very much.
Thanks very much, Rose. That was fantastic. Thank you very much. I think we were waiting for Zelda to join us, but I think she's having trouble joining. So we're going to go next to Yuhsin Huang from IPPF. Yuhsin, go ahead.
Thanks, Manjula, and thanks for giving IPPF this opportunity. Hello, everyone. Good morning, good afternoon, and good evening. I'm here to share IPPF's response to our today's topics. Next slide, please. Okay. IPPF is a leading service provider and advocate for cervix and reproductive health and rights. We work with different stakeholders, such as policymakers, CSO, and communities, to ensure our government protect and fulfill gender equality and sexual and reproductive health and rights. Through our member associations and collaborative partners, we delivered 223.2 million SRH services, including 95.4 million youth-friendly services in 2018. It is estimated that 80% of our clients were poor and vulnerable. Because of this, the result of the ECHO trial and the WHO's latest guidance statement are significant to our work. Next, please. IPPF places the client at the center of everything we do. We see it as a client's right to access comprehensive SRH information and services, including contraception, HIV, STI services, and to exercise the right to informed decision-making. Undoubtedly, the ECHO trial provides high-quality evidence to inform decision-making for sexually active adults and young people. The following WHO guidance and recommendation provides clear messages for policymakers, project managers, SRH organizations, and health providers to support the right of women and girls to have access to broader contraceptive options. Moreover, it ensures women's risk of HIV does not limit her contraceptive choices. IPPF really sees this as an opportunity to reaffirm the importance of our member associations, providing rights-based SRHR information and services. Through this, our member association can continue to support all people in realizing their reproductive choices as part of an integrated package of SRHR interventions. Some actions include, first, providing SRH counseling that is free of stigma, discrimination, and coercion. Second, implementing IPPF's integrated package of essential services, which promotes service provision for the most pressing SRH needs of the population. Last, strengthening prevention of HIV and other STI through SRHR and HIV STI services integrations. and also provision of PrEP in countries with high HIV incidence and for people with needs. Next slide, please. IPPF set up an eco-trial working group to provide technical support and guidance to the Federation. Representatives are from IPPF member associations, regional offices, and the central office. The working group has conducted webinars and developed internal briefings and technical briefs. In addition to this, our International Medical Advisory Panel, IMAP, issued a statement following the release of the ECHO trial. 5 things are highlighted in this product, including the importance of a women-centered approach, informed decision-making, young people, the need for a broad method mix, and an integrated approach, especially stepping up HIV/STI prevention. Following on the release of the WHO guidance statement and the revised MAC, IMAP is preparing a follow-up statement. The ECHO trial working group is also preparing a technical brief and a webinar to ensure our providers are capable to provide appropriate counseling as well as updated, accurate, and complete information. In addition to this, our member associations, regional offices, and project managers use different platforms such as regional meetings and project workshops to widely disseminate the WHO guidance and recommendation, as well as our products. Next slide, please. So next step for IPPF is we will continue to strengthen HIV service delivery, including HIV prevention, testing, and treatment. We will ensure that clients have access to broader HIV prevention options to meet their needs and preferences. This option should include risk reduction counseling, male and female condoms, pre-exposure and post-exposure prophylaxis, and voluntary medical male circumcision. We also believe that self-care intervention can empower clients and increase access to desired SRH services, particularly for young people and marginalized populations. IPPF is prioritizing work on self-care interventions to complement our service delivery models. Moreover, IPPF is looking for the opportunity to work with other organizations to introduce, promote easy-to-use and multi-purpose prevention technologies to prevent unintended pregnancy and protect against HIV and other STIs. Next slide, please. The results of the ECHO trial remind us of the risk of vertical programs and the need to accelerate efforts in HIV and STI services as a key part of SRHR services. In many countries, HIV, STIs, and contraception programs are located in different departments. To better and efficiently use limited resources, national actors, including the Ministry of Health, should promote and coordinate integration of these programs at all levels. Our member association will work with national actors to accelerate efforts in integrating HIV/STI prevention, testing, and treatment. The truth is, advocacy work and service delivery should not be discussed separately. Following the release of the WHO guidance statement, it is expected that WHO will provide the implementation guidance and toolkit in the coming months. Our member associations, especially those are already part of the national task teams, will work with national actors to support the updating of national policies, guidelines, protocol, and training manuals. Advocate for wide mass mix of contraceptive and HIV prevention methods for women and girls. Advocate that donor and domestic government funding be allocated for a wide method mix, rather than promoting any specific method over others. Next, please. Our conclusion for today's presentation is the result of ECHO trial is not a relief, but a wake-up call to action. It highlights the lack of effectively integrated SRH approaches, which has implications for vulnerable communities. The results call for action to ensure women and girls are able to make informed decisions and choices about their reproduction, free of stigma and discrimination. And women and girls, they should have access to a wide method mix of contraceptives and access to comprehensive HIV, STI information, prevention, and treatment services. In the end, IPPF wants to emphasize comprehensive and integrated SRHR must be provided as part of a universal health coverage. The goal of reaching universal health coverage is only possible if all people, especially women, girls, and other marginalized populations, has access to SRH information, education, and services. Next slide, please. So this is the last slide of my presentation. Once again, thanks for giving us this opportunity. And please feel free to contact us and ask any question. Thank you. Thanks, Majella.
Thanks so much, Yuhsin. And we'll go next to the presentation by James Kiarie from the World Health Organization.
So thank you very much to the organizers for inviting me to present today on my thoughts on what needs to happen so that we can scale up integrated SRHR and HIV services following both the ECHO trial and the issuance of WHO guidance on contraception for women at high risk for HIV. So on the next slide, the guidance on HIV and contraception that has been recently issued by the World Health Organization actually highlights several implications for policies, programs, and for providers. And this is what we need to happen to respond to both the findings of the ECHO study that has been presented and the real need to integrate services. One is that there should be no restriction over women's contraception options based on HIV infection risk. There is need for us to expand access to more contraceptive options, really to expand the method mix. And then the need for integration of family planning and STI prevention services. And I think which is really the focus for us today, looking at integration of family planning and HIV prevention services. So on the next slide, what needs to happen is very important. One of the things that are critical as we think about this is that really at this point, decisions and plans have to be made at national and subnational level. I think the time for discussions at the global level has now moved on to actual discussions and decisions at the national level. Then we need to address the issue that these programs have been siloed for a long time. There are differences in funding, in policies, in the commodity supply chains, in the way data and information is captured, in service delivery, in the workforce, and also between HIV particularly and family planning. These differences will need to be addressed and will need to be brought closer together. Then we need to think about previous failures. Efforts to integrate services have been ongoing for a long, long time, and we need to really examine why we have not progressed and address some of the reasons that have led to failure in the past. There's, I think, limited need for additional policies, guidelines, tools, or strategies. Because we already have plenty of this. We actually do know how to do this. It's only that we need to take action and get it done. And then any efforts that we are thinking about must be resourced. Without the resources to do this, then it will not progress. And on the next slide, if we think what is our contribution as a global community, we can generate the evidence, we can generate guidelines and tools, which I've said we already have. We need to develop partnerships, provide technical assistance, advocacy and leadership. And for those who are funders, they need to think about funding. But eventually, this will need to translate to country intention and readiness to act on integration, and country actions that need to be then taken to eventually lead to integrated SRHR and HIV services. And it will be important for countries to identify outcomes that will eventually lead to this goal, so that they can have a very clear process of how this will be achieved. So on the next slide, I would like to spend a bit of time to discuss what it means for countries to have the intentions and to be ready for SRHR HIV integration. It's important, for one, that we have clarity on what the integrated services will look like. Who will provide them, what skills, and in what structures will they be provided. And we need to identify what aspects of policy, program, and service delivery that we currently have are inconsistent with integration, and address those policies, programs, and service delivery approaches that are hindering integration. We need to be very clear that there are changes that will be required. I think without changing the system in terms of capacity, in terms of resources or structures, there is no progress that will be possible towards integration. There's need to have plans which need to be costed. We need to have clear metrics of what outcomes we want, what outputs we'll have. But I think the most important thing, and which we will not make progress without, is we need an implementation team. We need a team that is responsible for implementing SRHR HIV integration. And I think, fortunately, as a follow-up from our preparations for release of the ECHO trial, our preparations for release of the WHO guidelines, and our preparations for their implementation, we already have task teams in various countries that draw both experts from HIV and from family planning. What will be critical at this juncture is to convert those task teams into implementation teams that will be charged with a responsibility to get the national and subnational levels ready for SRHR HIV integration. And not only ready, but to actually drive the actions that will then lead to the integrated services. So this need for an implementation team, I think, cannot be overemphasized. If we do not have a team or individuals that are responsible for moving this forward, then we will need to just think that it's unlikely to happen. And on the next slide, so what are some of the possible actions? And I think this list here is not supposed to be exhaustive. There are many actions that need to be taken into countries, and the implementation team will need to identify the specific actions, but resources will definitely be at the head of some of the actions, availing resources for these processes, training of providers. I think the processes for technical assistance and for supervision, particularly supportive supervision, will be very important, because for many people, this will be new services that they are not familiar with. We need to look at the workflow in the clinics. It's very important to realize, particularly when we focus on family planning, the women are coming to these service delivery sites for family planning. They come to prevent unintended pregnancy. We would like to add another delivery of another service. It's important that we ensure that what the women came seeking is delivered, plus the additional service. And for this to be achieved, we need to look at the workflow, that we do not disrupt the workflow, and that whatever additional services are provided are done in a way that complement what is already being done. We need to streamline data and commodity supply systems. Currently, this for SRHR and for HIV, there's a lot of differences, and these need to be put together. So we are not just doubling the need for staff to be spending a lot of time filling data sheets, and also not creating challenges for getting commodities, because they now have to order commodities for SRHR from one source and commodities for HIV prevention from another source. So we need to streamline this and make it easy for the integration of services. And then the continuous improvement, and one of the approaches that I've proposed is to do the plan, do, check, act cycles. This can optimize implementation. As for many places, this will be something that will be new, or that has not been done. It has been done in pilot, but has not really been scaled up. So for many providers, it will be new. It will be always important to revisit and see what is working and what is not working, and improve. So on the next slide. So in summary, I would just like to say that ECHO is done, an excellent study, has very important findings, and I really congratulate all the investigators that were involved in this study. For WHO, we have issued the revised guidance on contraception for women at high risk of HIV infection, which is available. And there's a previously recorded webinar presenting that guidance. If you'd like to know more, you can go to that webinar. What we need now is to move to national and subnational implementation. We need to think about scaling up SRHR HIV integration. And this will not be easy. It will be challenging. We know there have been failures, attempts that have not worked, but I think it will be feasible and successful if we address some of the siloed thinking between services that has been there, and really address some of the things that may make this not feasible. And also, importantly, we need again to emphasize, if we can leverage the existing task teams, which are already in country, and convert them to implementation teams, then we can be able to move forward. And also, importantly, will be commitment of resources to support this process. This is a great opportunity, and it will be successful if we utilize the resources that already exist. We have the guidelines, we have the tools, and we have the processes in country that will enable us implement SRHR HIV integration. And on the last slide, I'd just like to say thank you very much for your attention. And you can find a lot of the documents in that website for the departments. And we are always having communications regarding the latest on sexual reproductive health and rights, and also on including SRHR HIV integration. You can follow us at our Twitter link there. So thank you very much.
Thank you, James, for that presentation. And we do have Zelda online, and we will now move to Zelda's presentation. And apologies for the little echo at the beginning of the presentation of James, and which was fixed, and I think you were able to hear the rest of the presentation. Zelda, over to you. Zelda, are you online? I think we're still having some trouble connecting with Zelda, so let me just say a few words while, and we'll still...
Jula?
Yes.
Yes, hi.
Ah, hello, Zelda. Over to you.
Yes, thank you very much, and apologies for those difficulties. So, for me, I just want to share, as we have already heard from the earlier presenters about integrating SRH and HIV. So I just want to share how we do it here at Family Life Association of Eswatini in terms of service delivery. Perhaps I'll just start by introducing my organization, which is FLAS, commonly known as FLAS, located in the southern parts of Africa. We are an NGO and a member association of the International Planned Parenthood Federation. And our core business is sexual and reproductive health, which of course includes HIV and AIDS. And we focus primarily working with the young people, 10 to 24 years, but of course we do also serve the adults. And in terms of what we do, that's the next slide. We provide integrated services, SRH services, as well as information to young people in communities and in schools. But of course, we also undertake a lot of advocacy work. Therefore, we also get involved in doing research studies, as we might have heard earlier that we have also been involved in doing in the ECHO study. FLAS also nationally is also known as the Center for Integration of SRH and HIV. The country and other partners have learned how to do integration from us. And this is what I would like to share here. Next slide, please. The FLAS integration model basically is one where we are putting the clients at the center. So the integration that we do is at a service provider level. And what we mean there is that the service provider provides all the services both SRH and HIV. So when a client gets into the consultation room, she or he will get everything that they need from the service provider, including education, including the service itself. So there is very minimal referral. The referral that we have internally is mainly to the lab. Other than that, everything is done by one service provider within one consultation room. And the approach really is that we listen to the clients, because we have an understanding that when a person walks in, they have needs, they have preferences, they have wants, they have interests, they have fears, and everything. And therefore, we engage with that person so that by the time they go out, even though they had come for a particular service, at the end they get more of what they might have needed, but were not aware that they needed that. We basically, therefore, follow the rights-based approach, whereby we are putting the person at the center. And we also prioritize the range of services, because we also believe that people must have choice in the various services. And therefore, if I can just give an example of family planning services, we make sure that we have a broad range because of that appreciation that people have got different preferences. And also we try as much as possible to make sure that the services are affordable. So in that way as well, we've also progressively been adding new services as we move along, as we identify much more efficient and affordable services. And also because of the needs of people, and also from learning, we've also find ourselves introducing services that previously we had not prioritized. So for example, if you have known FLAS 10 years ago, you will find that the services that we offer now are much more different, they're much more wider. We now offer even NCDs because those have been an emerging issue, and therefore, as we moved along, we have had to add those. Next slide, please. This slide, basically, I will not go through it, but it just highlights the different services that we provide at the facilities of FLAS. So it's both sexual and reproductive health and HIV services. And therefore, if I can go to the next slide. This slide kind of summarizes, for example, what we did in 2018. So we can see that we provided about 338,000 services to 43,000 clients. And that indicates that each client had a minimum of about 8 services. So this actually indicates, this approach indicates that it's possible to do integration as long as you put the person at the center, because that's the only approach that will enable you to avail the different services to the person. Next slide, please. So maybe here I just wanted to share what we've put in place, or what has enabled us to be able to do integration. We've had various systems that we've put in place which enable us to assist service providers to make sure that they are doing the integration. So we have systems, we have tools that we have in place, but also and most importantly, the national policy, the national policy environment, the guidelines, they now support integration in the country. So, for example, if I provide FP, the guidelines also stipulates that you also have to do cervical cancer, you have to do HTS, you know, all those services. So they help in terms of providing the integrated services. And then also what we do is we have displayed the rights. We make sure that clients, as they walk in, they can see their rights, the client's rights. We place them in very visible places so that they can be comfortable. As soon as they walk in, they know that, oh, I can do this, I can get information if I want it. This place respects diversity, you know, and that way already we've already made the person to be comfortable just walking into the facility. So by the time they go in to the service provider, they are free, they know what they can do. And we are continuously listening to the clients. For example, as I mentioned earlier, that our focus is the young people. They shared, for example, that for them it's embarrassing to carry condoms in their handbags. So we introduced some neat, discreet packaging of condoms, which they like. We display this in the waiting area and they take it, looks neat. No one can ever know that inside there is a condom. And with this, we saw more and more of these young people taking those condoms, and we trust that they're using them. And also the data tools, they also enable service provider to ensure that they do the integration. And we are an organization that is continuously learning, including the service providers. They are also continuously learning. Next slide, please. I think the benefits have been shared earlier on, but briefly here, I just want to share about the person approach. So here we know that I do the person's approach, I make sure that I'm addressing multiple clients' health needs at once, including education for the person. So by the time the person leaves the facility, they know more and they have received more services. And of course, for us, we've found that it is efficient in terms of, especially of in terms of resources, such as mainly the human resources. So a service provider can implement or can provide all the services. They don't need to say, let me call so and so to come and help you with the insertion of IUD or whatever. Everyone can perform these services efficiently. So they are multi-skilled, and the service providers, they really appreciate this. And most of all, the clients are happy. Yes, they are unhappy when they are sitting in the waiting area because there is a bit of a long waiting time. A client takes long in the consultation room, but once they get inside, they leave the facility happy. And we found that because of the economic situation, We've had to introduce some user fees, which we know they can be a barrier to access, but they're essential for the sustainability, especially for an NGO. And of course, we also note that there is a service provider burnout with this process, because as we have already shared, it is highly intense. And that was my last slide. Thank you very much. Yes, there are contacts there where you can contact us, including social media. Thank you very much.
Zelda, thank you very much. And unfortunately, we're at the top of the hour and we won't be able to take any questions, but please do feel free to contact any of us, and or we will try and send responses to the questions that have been included on the right-hand side panel. You will see on the slide here the MEC app on the update of the medical eligibility criteria, and this information is also available on the websites that have been shared. So just very quickly to wrap up, I think the need to break down the silos, both at institutional and funding levels, is not a new message. It's a message that we have been sharing for quite some time, and really the need again for that person-centered care that has been mentioned by several of the speakers to address the needs of a woman and a girl's autonomy and agency and give her informed choice is something that is going to be essential. And we can't do this without real change. And as that was also mentioned, that we can't do things as they are now. There really does need to be some change and stronger intersectoral approaches. And as was mentioned, we have guidelines, we have the tools, we have processes, and it also includes a new sort of element that is available, which is guidelines for self-care. And in addition to the services, we can promote autonomy and person-centered approach through self-injectable of contraception, HIV self-testing, and again, guidelines and tools are available for this, and really highlights that need for that person-centered approach. So thank you all very, very much for your time, and a big thank you to all the panelists and the organizers of this webinar and the Interagency Working Group members. Thank you and have a good day.